Thank you. And I am the weak ring of the chain because if sepsis is a strong item, liver failure is a question mark. So I have changed a little bit my title with this question mark. And perhaps at the end of my presentation, I hope we can change a little bit the title, my disclosures, and to speak the same language, some definition. For those who are not so familiar with liver failure is an impaired capacity of the liver to maintain some of very important functions, which is synthetic, excretory, and detoxifying. Main characteristics are injury. Liver injury means increase of transaminase. Liver dysfunction is a little bit different story. Means change in coagulation parameters. There is a long story now, and I don't want to go in. Detoxification, ammonia, and bilirubinemia, hyperbilirubinemia. These are the usual signs of dysfunction. We have acute liver failure, and these are examples of the acute liver failure. We have liver failure in medical situation and in surgical situation. For example, after major liver resection, instead of after liver transplantation, you have primary graft non-function instead of early allograft dysfunction. Or we have this new, brand new, not brand new, but it's a new entity, syndrome, which is acute and chronic liver failure. And acute and chronic liver failure are a little bit different. I'll show you now. The acute liver failure is an acute liver failure according to the data I gave you before, but without any pre-existing liver disease, which is very important. And according to the interval between icterus or jaundice and encephalopathy, which is the critical tract of acute liver failure, you can differentiate your syndrome, acute liver failure, in acute, hyperacute, or subacute. And the longer is the interval, the higher is the interval, the worse is the prognosis, which is quite countercurrent. Acute liver failure per se is not just an insult to the liver, but is a disaster on the organism. And what I fear is the reflexes on the entire organism, yes, but also on the central nervous system. And in particular because brain edema can develop. According to the most recent explanations, this disaster is sustained mainly by a strong, severe hyperinflammation reaction mediated by cytokines and the so-called damage-related or associated molecules, which are relevant in the full-blown syndrome, and the higher, the more severe is this reaction, the higher, the more severe is the reflections on brain system. This is what I fear. There is not only a systemic reaction, systemic inflammatory reaction, but there is also a so-called CARS, which is a sort of counteracting or compensatory anti-inflammatory reaction. Now it is called or is defined SARS, systemic anti-inflammatory reaction, which is able to increase the incidence of infection, and this is very important, and it is able, SIRS and CARS or SARS as you want, to increase the severity of brain dysfunction or the severity of brain edema. Acute and chronic is different. Is a chronic liver disease on which a new dysfunction is coming up. Is coming up according to a sort of severity of various organ dysfunction, and this is the score, the so-called Cliff score, to define, to grade the severity of the acute and chronic liver dysfunction. Of course, the more is the score, or the higher is the score, the worse is the prognosis. And again here, we have again this systemic inflammatory response which plays a relevant, a critical, pivotal, as you want, role in maintaining this kind of insult, of injury. And since both conditions can be very important in this kind of response, because of infection, for example, so we have cytokines, but we have also so-called PAMPs, pathogen-associated molecular, right? And DAMPs, because the liver is killer, but also the victim of this situation, which is very intriguing. Is it true? Yes. This is very well demonstrated by the group chaired by Professor Vicente Arrojo from Spain. They were able to demonstrate a great increase in cytokines, both inflammatory and anti-inflammatory, in patients with acute and chronic liver failure. More, according to the severity of the disease, you have an increase in cytokines. So the more severe is the syndrome, the more cytokines are growing up. And I'm telling you, in some sense, that cytokine storm is not a minor entity, both in acute and chronic liver failure. Bacterial, for example, is an adjunctive to the severity of cytokine release. So again, more and more severe is the story if you have over the liver condition, the bacterial infection or septic condition. This is very important. And in this setting, could an extracorporeal support have a sense, or could it make sense? Why not? Is said by these two really leaders in the field. Kirvelas is from Canada, and they were commenting a very, very important study dealing with one of the artificial support in acute or acute and chronic liver failure. They say, in the title, could it dampen this response? And why could be important an artificial support? Because you can remove all these cytokines, toxics, and as you want. But we must say, no system at the moment, so far as yet, is able to change the outcome, mortality. You can change, or a sort of cosmetic, bilirubin. You can have better hemodynamic profile. You can have better central nervous system profile, not encephalopathic. But you have no reflex on mortality, but the very last who came, and the original, which is high volume plasma exchange. This study, I like this study very much. I like this study very much because I like Professor Larsen very much. He was able to demonstrate for the first time that plasma exchange is able to change morbidity and mortality, both with liver transplant and without liver transplant. And this is the only extracorporeal device able to do this. But what I want to address now is this sentence they wrote on the paper. And the sentence is, we suggest that early application can modulate the pro-inflammatory storm and limits the anti-inflammatory response, providing a window of homeostasis, etc. So they have written what, into my opinion, could be a role. I am trying to giving you a rationale. I hope to convince you. I am convincing for a role of this device in modulating, as I say, acute and chronic liver failure, both medical and post-surgical. This, why could be? Could be because CytoSorb is able to remove cytokines, dampen MAMs, toxics. And among the toxics, I am really happy of ammonia, and I'll try now to show you why. You could ask me, where is your literature or scientific support? Not too much. Four papers published now on PubMed, if you look at it. This is not yet published. It's done by an Italian doctor, is Professor Faenza from Bologna. They were able to demonstrate in vitro that CytoSorb is able to remove, in a short period of time, 8 hours in this case, bilirubin. This is a model in vitro. It is able to reduce very well, I must say, bilirubin in 24 hours, which is the length of the device, of the absorber of CytoSorb cartridge, and without removing albumin. And this, into my opinion, is very important. It's a sort of rinse of albumin. And albumin now has a peculiar role. I don't want to talk of albumin now. They were able to bridge towards a retransplantation, a terrible situation known as primary graft non-function. For those who are not familiar with liver transplant, primary graft non-function is the worst situation we can face, and is the liver that doesn't work after the implantation, after the perfusion. And if you have, should you have primary graft non-function, either retransplant the patient in 4 or 5 days, or the patient is dead. They were able to bridge to the next transplant this patient, and they were able to reduce. In this case, they were very, very attracted by bilirubin. Into my opinion, yes, bilirubin is yes, but why bilirubin? Hyperbilirubinemia in this case, because the liver it does not work. But there are more than bilirubin to destroy our, the organism. This is what, not the CytoSorb. CytoSorb work here, very nice. This is the new liver which worked. So you see how important it is to remove all the toxics. And perhaps we have something which can help us in removing toxics and buy time. Because in this situation, time is wonderful, is paramount. But what I am really concerned is ammonium or ammonia. If the liver works, no problem. You recycle and you manage, you handle all the ammonia you want. But as is clearly shown in this article last year in New England Journal of Medicine by Weidix, who is the neurointensivist of Mayo Clinic, Rochester, Minnesota, he says, when liver fails, brain function changes. and how it changes, particularly during acute liver failure, not acute and chronic, acute liver failure, we have the risk of brain edema, brain edema and brain stem injury, which means life-threatening condition. How can we measure hepatic encephalopathy? The old West Haven classification or score, as you want, is something a little bit subjective. The patient is arousable, yes, but he's very agitated. He continues to repeat words and so on, or he's going down towards coma. He has no reflection, no protection reflections. A little bit subjective. Very, very recently, this 4 score has been built up, and as you can see, it's a sort of Glasgow coma scale, including eye reflexes, motor reflexes, brainstem reflexes, and respiration. So you can go from 0,3, Glasgow 3, towards 16,15, according, yes, to some subjective symptoms, but taking many very objective data or symptoms. So the story is completely different when you are dealing with the acute and chronic story instead of the acute liver failure. In the acute liver failure, you have brain edema with this kind of mechanism. You have a lot of ammonia, which is taken up by astrocytes, and in the astrocytes, this glutamine synthetase convert ammonia and glutamate in glutamine. And glutamine, as is written here, acts as an osmolyte, which means attract water and the brain swollen, which means brain edema and risk of brainstem damages. This is why I'm really concerned, this is the result, of course, of hyperammonemia in this kind of situation. My 2 chairs are 2 nephrologists, and they could tell me, Dr. De Gasperi, you should know that with a very well managed CVV, continuous renal replacement therapy, you can handle ammonia. This is true. It was done by the King's College group, a comparison between ultrafiltration of ammonia and ultrafiltration of urea. And they were able to demonstrate that with a good urea ultrafiltration, you can have a good ammonia removal. How much? 20%. Starting from, they published on, starting from 100 and something to 100 and something less. 20%. I am not concerned of 120. I am concerned of more than 200, which is the terrifying level of ammonia because it increased the risk of brain edema. Then, if I have not the chance of being able to manage or to handle hyperammonemia with CRRT, as was done in this case, they tried CytoSorb in a condition of acute and chronic liver failure with acute renal failure, and they put the CytoSorb on the circuit, and they try to, as they say, last ditch, last resort, to manage this condition. And in this study, which is a letter, which is not a study, it's a letter, that published a few months ago, they were able to demonstrate that ammonia was cleared, in spite of CRRT, as you say. Same results were done by another German group a few months ago, and the story is the same. They had CVVH, which was not able to handle, evidently, the ammonium. They tried to reduce with CytoSorb the ammonia. In the few minutes I have still, I want to show you a case we did, the first case I did with CytoSorb in January. We were desperate with this patient who were liver transplanted for hepatopulmonary syndrome, which means very high hypoxia in breathing in the air. We had quite a tough course during the operation, the procedure. The patient was still hypoxic after the procedure, very, very early after the procedure. We had what we call a early allograft dysfunction, not because of function, but because of injury. 4,000 transaminase, but bilirubin not that bad, lactate not that bad, but ammonia 200 in this case, and oliguria and acute renal failure. Stopping sedation, we were really frightened when we saw a Glasgow Coma Scale 3, or if you want a 4 or 0, close to nothing. We performed suddenly a CT scan, cerebral CT scan, to rule out edema. I must say, CAT scan is not the best exams, but we were really afraid. No brain edema, so negative predictive power is fine. It's not exceptional, but it's fine. No hemorrhage. This is the EEG trace. For those who are not familiar, this is a bar suppression pattern, and these are the so-called triphasic waves. Hepatic encephalopathy, severe hepatic encephalopathy is a marker. Is a marker. The day after the EEG trace was close to the same. We had not that bad numbers for function, but if you look at the ammonia was 400. So I was really afraid. This was close to the 5 o'clock in the afternoon, Friday. So I had the opportunity to start a treatment with the CytoSorb. This is the result of the first treatment, 24 hours. Of course, this is a case. This is not a demonstration, but it's tailored therapy. In 24 hours, we had a decrease of ammonium from 400 and something to 170. We performed a second treatment. The second treatment was able to reduce more the ammonia, and the patient the day after was arousable. The liver did better, and you could say, yes, you tell me that this was extubated, was fine. This is EEG, which is normal. You can have this kind of EEG in acute liver failure when you transplant the patient. So I was impressed by these results. I must say, and I am going to conclude, we did 3 cases more. The removal of ammonia was not that sharp, but indeed ammonia was either stable or decreased, which means in presence of an increased production and in presence of life-threatening condition like that, I think I might have a device, a tool, able to control, to modulate my condition. To conclude, this is not an evidence-based presentation, just perhaps, as Professor Ronco told before, a tailored therapy. I think CytoSorb, I believe in this, it has a rationale in dampening or modulating, as Professor Honoré showed before, so-called cytokine storms, because and supporting the liver in acute and chronic liver failure, in drug-induced liver injury, in post-operative or post-transplant graft dysfunction or non-function, because of the ability of removing this kind of toxics. Just give me 1 second to show you that early allograft dysfunction, which is a condition that jeopardizes the new graft, is associated with a cytokine storm. Since it could jeopardize the life of the graft, the life of the patient, everything, we think that with this kind of explanation, we can have at least, as I say, an idea to modulate or to influence or to impact on this condition. Last, we have very, very, very few publications so far, but they are promising, into my opinion. I showed the 2-3 letters. Biases, of course, are present. We don't know in other treatments which are not being reported results. So this is why we have not yet, at least not yet, a magic bullet. We have to design, as appropriately addressed Professor Honoré, well-designed study, with which I don't have to say at the end of the study, my study is not powered for. I have to decide before what I want to be powered for. Endpoints should be clear, very clearly defined, and perhaps, and into my opinion, this is a strong argument, bridging to liver transplant in acute liver failure, or modulating the entire story in primary graft non-function or early allograft dysfunction could be an option. This is my very last slide. I should rewrite the title with new option to modulate liver failure and to impact on hepatic encephalopathy. Question mark, up to you. Thank you.
Thank you, Professor de Gasperi, for sharing these very exciting data and exciting stories. We have time for 1 or 2 very short questions. Are there any questions from the audience?
I can ask you something very quickly. Did you test the capacity of absorption of bilirubin, and if so, when do you find the saturation point?
I didn't do that. This was done by Professor Faenza in vitro in Bologna, and they say the capacity seems to be really great. I have no data, but I am relying upon data coming from an in vitro study and few in vivo studies.
Okay, thank you.
Sorry.
You were also referring about removal of antibiotics and removal of hormones. I must say that we have a paper which is approximately 2002, I think, in blood purification, describing the capacity of removal and rejection of this adsorbent for antibiotics and for hormones. So I think it would be important to add in the knowledge of this process.
Sorry for my not having presented this data. There is, yes, together with the flow I show dealing with MAMS, DAMS, cytokines and so on, there were data dealing with antibiotics, not that much removed, apart from aminoglycosides.
Right.
Correct?
Right.
I studied.